Hi. Don Landry. It should be the most recent lecture if you list them by date.
By date, okay.
Should say something about shock. Let's see what it says.
Shock first year, 511.
Yep. Hey, things are fine. What time do you guys begin?
We're punctual. I'm making sure.
Oh, you really?
Well, actually,
Within a few minutes.
everyone in the class will see these twice on the recording. So don't be
Okay.
taken by these things.
All right.
Seriously. Thanks, Don.
All right. Thank you. Okay. Cold water. So, although this is the nephrology section, maybe because I was formerly a member of this division, it allows me to speak. We're going to talk about shock. Shock is definitely related to the kidney. Shock affects the kidney. Kidney is a major organ for volume homeostasis, volume derangement is one of the etiologies of shock. So it's as good a time as any to touch on shock. But as you'll see, shock actually weaves through very many of the sections we've been doing in this class. And some of the ones that you will be doing. We've got to get into it at some point, and this is, I think, the time to do it. The organization of the lecture is going to be a little bit of physiology of blood pressure regulation, so it's a little reminder of cardiology. It looks at shock and various etiologies. It looks at the various treatments. And it concludes with a little bit on vasopressor, which is now part of the management of vasodilatory shock. But also, the other types of shock that have been around for a long time is the men that get vasodilatory components. We'll discuss that also. There's a subtext in this lecture, and that is that based on the last third of the lecture on vasopressin, on clinical observation. So I'm an organic chemist by trade, so medical school, a PhD in organic chemistry, and I'm running the basic science lab. And I'm fulfilling my teaching requirements by serving as a nephrology consultant in the ICU. And I observed something. This can be used, not so long from now. Whether you are planning to be an investigator, or you're planning to be a full-time clinician, or some combination of the two, you'll make observations. And one of these observations could be a completely new window on medical reality. If you end up taking the fourth-year course in advanced pathophysiology, then you could spend 3 hours on this. Today we spend about 15 minutes. So, see if I can do this without messing up too much. I have no disclosures on this topic. We have some objectives, and let's get to it.
Oh, my goodness. Could the home audience tell anything from what I just said? Or nothing? Who knows? Okay. For those of you at home, we'll review the physiology of blood pressure and shock, and then discuss an observation that was made here at Columbia that's now part of the standard management of vasodilatory shock. So first of all, a definition. Shock is not a state of surprise. Shock is a state of low blood pressure. And it's low blood pressure, typically systolic less than 90, okay, or 40 below baseline. So if you have a patient who's normally hypertensive, blood pressure running 200, could be that that blood pressure of 120 over 80 is actually shock for that patient. Okay? The vessels may be damaged. The resistance may be up. When the pressure drops to that level, perhaps the actual perfusion pressure to the organs is sufficiently low that we meet the other side of the coin. It's conjunction and evidence of end organ hyperperfusion. Okay, and we'll discuss what those end organs are and how we might recognize that they are being hyperperfused. It's possible for a young woman, vegetarian, low-salt diet, to have a blood pressure of 85 and not have evidence of end organ hypoperfusion and be completely normal. So blood pressure less than 90 per se is not enough. Okay, there has to be evidence of end organ hypoperfusion. The etiologies are fairly clear. One would be hypovolemia, where you don't fill the heart, so cardiac output is down. Cardiogenic, you're filling the heart, but it's not pumping for one reason or another. The valves are incompetent, the muscle's not working. There's a group that's sometimes lumped in cardiogenic, but technically speaking is extracardiac obstruction, so something like tamponade. And then, pulmonary thrombosis with a large saddle embolism. And then we have distributive shock, vasodilatory shock. For hypovolemic shock, the etiologies can be broken up further. There are cases of hemorrhage, fluid depletion, extracellular fluid depletion. And it should be clear from the clinical context what's going on. For the cardiogenic, again, myopathic and acute MI, severe cardiomyopathy, trending toward cardiogenic shock. There are various mechanical problems with valves, aneurysm, LV outflow obstruction. Technically speaking, if you're looking at a patient with a profound arrhythmia, that arrhythmia can cause shock. Okay? When someone's in cardiac arrest, we usually don't think of that as a shock state. That's an arrest state, but that really is a shock state. At that moment, the end organs are not being perfused. They are being damaged. Extracardiac obstructive etiologies, there are 3. Probably it's good to have these in the back of your mind, because if you don't think about them consciously, you're not going to remember them in a moment of crisis. But pericardial tamponade, pulmonary embolism that's massive, and pulmonary hypertension that's severe. What's the physiology? For distributive shock, decrease in blood pressure due to a massive decrease in resistance, systemic vascular resistance, despite the fact that cardiac output can be up. Sometimes it's normal. With fluid resuscitation, it can be elevated. Distributive etiology, most commonly sepsis. But it's also possible to have a patient who's inadvertently taken an overdose of a vasodilator. And then there's the category of irreversible shock. And this is shock, for instance, hypovolemic, cardiogenic, that's profound and prolonged. Okay, so a patient in the OR starts hemorrhaging, and it's a very difficult case, and they, after exceeding effort, finally get control. The patient's had low blood pressure for a long time, perhaps has even gotten suppressors. Finally, though, the bleeding is staunched, the volume is returned to normal, but the patient is still in shock. Okay. And those patients that end up in the surgical ICU after rough surgery, or they come out of a trauma bay from the ED, and that's an irreversible shock case. This is a diagram, good one to have in your mind, good one to have in an index card when you're on the wards. If you think about the cases of decreased cardiac output, they can be divided up into those where filling pressure is low, hypovolemic, and those where it's elevated, cardiogenic. For the distributive shock, septic shock, that's going to be a low SVR. The filling pressures can be down in early sepsis after treatment with volume, with fluid, with crystalloid, okay, isotonic saline. Filling pressures rise, but still in a shock state. But now cardiac output is normal to elevated, and yet the patient is still in shock, and that's a volume-treated sepsis. So this is a nice, neat diagram, and this is the way you should try and remember it. But this is some real data, actually. And here we have total peripheral resistance. Okay, so this is a high resistance, low output state. This is a low resistance, potentially high output state. We see hypovolemic, cardiogenic, septic, but they're not neat little boxes. So there can be overlap. And when these start to move down into the lower register, and they start to overlap with septic shock, those are often the profound and prolonged cases that are entering the irreversible phase. Now, it's not enough that you just have low blood pressure, or relatively low blood pressure for the baseline. And that's why when you're getting history, it's always important to note what is the baseline blood pressure of your patient. But we have to have end organ hypoperfusion. How do we assess that? Well, hypotension is sort of the ticket for entry. That doesn't shed any light on this. But you'll see tachycardia. You may see clouded sensorium, okay, decreased ability to mentate, not perfusing the brain. Oliguria, okay, something from the renal section of this course, making a low volume of urine. Lactic acidosis. So lactate is a critical marker for shock. And there are some patients where blood pressure has not quite fallen yet, but lactate is up. And that's a hint of someone who's about to go into fluid shock. So there are lots of compensatory mechanisms going on. When they finally collapse, it's pretty clear. when they're heading into the collapse, it can be subtle. So having an index of suspicion and doing something like checking a lactate level is an important way to differentiate. Low flow states, so that would be hypovolemic shock, cardiogenic shock. You'll see typically cold extremities, okay, clamped down peripherally, okay, modeling, libido reticularis. And then depending on the etiology, for instance, if it's hypovolemic, you might see signs and symptoms of bleeding, or the patient might have diarrhea, diarrhea plus vomiting. Cardiogenic, you might have the signs and symptoms of heart failure, see appropriate murmurs if there are valve lesions. High flow would be the distributor shock states. And there you might expect to see extremities that are overall on the warm side. And maybe they're just not cold. These things can get complicated. If you have a patient with a DVT, maybe you can't rely, deep venous thrombosis. Maybe the extremity is warm, and maybe you're being fooled by it. So you have to always think about the clinical context. Okay? But all things being equal, this would be how things might divide up. And here, if this is a distributive shock state, and it's most likely sepsis, you might expect to see the signs and symptoms of infection. The patient is febrile, has an elevated white count, has a left shift, has focal signs of an infection, cough productive of green sputum, okay. Consolidation, decreased breath sounds. The next two slides are just trying to make some connections for you. You need to make these connections on your own, okay? But if you think about hypovolemic shock, many of the topics of interest fall under the renal section of this course, and you may see signs and evaluate, say, the kidney performance in frank extracellular volume depletion. So you might expect, for instance, to see an elevated VU and creatinine ratio. The urine sodium is low. You know, all of the little markers, the FeNA, fractional excretion of sodium, might be low. There could be GI losses, diarrhea, GI bleed. Cardiogenic, that'll be your your cardiac section of this class. And then for distributive vasodilatory, the ID section for sepsis, and then individual organ sections with infection. It could be cholecystitis, or it could be pneumonia for the pulmonary section. And then finally, you can have sequelae that touch on the various things you've studied or will be studying shortly. But ARDS can be a sequelae of shock, of any etiology, particularly septic shock. Shock liver, particularly in patients who have high right-sided filling pressures, and then they become hypotensive. So the trans-organ gradient is actually low, and so you end up seeing elevations in the transaminases, AST, ALT. Digital necrosis from a shock state, often secondary to the pressors that were administered, but not every patient shows this, so it must be actually a pharmacogenomic issue, probably worthy of study. If you think about shock in the kidney in particular, whether it's acute renal failure, chronic renal failure, if this doesn't get better, volume overload in patients who end up with kidney failure and you're getting fluid and become flooded, hyponatremia, hyperkalemia, metabolic acidosis, lactic acidosis in particular. Hypocalcemia is an exacerbator. Hypocalcemia decreases the capacity of the vessels to constrict, so it can worsen vasodilatory shock. It decreases myocardial contractility. So all things being equal, if you have a patient who's significantly hypocalcemic and they're in a setting of shock, you might want to correct that hypocalcemia. Nephrolithiasis is a risk factor for infection and thus for sepsis. And if you do have nephrolithiasis and you do get infected, you can have pus under pressure. That's a particularly virulent septic state. And volume depletion, of course, is an etiology. So there are some connections to be made for what you've done in this portion of the course and what you have done and what you will do. So this is sort of a marker, but it's one that you need to fill in as you make progress from here to the wards. Treatment, it's pretty simple for hypovolemic. It's minimize the losses and start the replacement with whatever is appropriate. So it's a mechanical problem, and there are generally mechanical solutions. Same is true for cardiogenic. If it's myopathic, you maybe find yourself giving an inotropic agent. We'll go over the inotropes with a separate slide that I pulled from Cecil's. But it's good to remember that Mironone is an inodilator. So if there's also, in addition to the cardiac problem, a vasodilatory problem, this one's going to make it worse. Okay, whereas these two may be a little more neutral. This dopamine, a little bit more neutral. Mechanical, you may take a valve replacement. You could try afterload reduction for certain valve lesions, AI, for example. Arrhythmias need to be converted or defibrillated, and then obstruction will need the appropriate treatment for tamponade or pulmonary hypertension or thrombosis. But the one that's most complex and most difficult is vasodilatory shock. First and foremost is septic shock, sepsis. But there are others. Some worth mentioning here that can be seen but are rarely seen clinically. So I just want to highlight them so that you don't get sidetracked by them. But inadequate tissue oxygenation. You have to have a PO2 of about 25 or less to develop vasodilatory shock from hypoxemia and tissue hypoxia. Okay, so extremely low. Okay, it will not be subtle. You would rarely find a patient who was not in extremis showing you a PO2 down in the 20-25. Okay, it's a terminal event. Usually the patient is intubated, is on a ventilator, is on 100%, is on elevated PEEP, and despite all those things, it's dwindling down. And nowadays, the only thing for that would be something like ECMO. Carbon monoxide intoxication can do this, and this is a mode of exit for carbon monoxide intoxication, and eventually vasodilation, cardiac arrhythmias. Prolonged and severe hypotension from either hemorrhagic, cardiogenic, post-cardiopulmonary bypass, and you can find that even after these things are treated, after the patient on bypass has come off bypass and everything's good, the surgery went well, your patient may still be in shock. That can be a vasodilatory state. Okay. And then there are some metformin intoxication, particularly metformin in the setting of renal insufficiency, renal failure. Accumulates, you get toxic levels, you get a lactic acidosis, vasodilation, and shock. Cyanide will also do this. But the top one, and the one that you can't miss, is sepsis. So just pausing here for a second. The critical thing is to recognize shock. And you would be surprised and shocked to see that shock is sometimes neglected. And the blood pressure will be dwindling down. And there's no bright line where suddenly, bells and lights flash saying your patient is in shock. You've got to recognize it. And so knowing your patient's baseline blood pressure, having some concept of what would be low for this patient so that you don't get caught flat-footed. Okay. And then once you recognize it, then you put up your little Aristotelian square. You figure out where your patient is in the scheme of things. If you can't tell just offhand, then you collect data so you can figure it out. And then you start treating. But some more about sepsis. So a systemic inflammatory response syndrome manifested by a febrile state or a hypothermic state, elevated respiratory rate, elevated white count, or a low white count. These will all be the hints that you've got someone who has something going on in this axis. Now, whether it's infection or not depends on whether or not, or sepsis depends on whether that there's presumed or confirmed infectious process. And so this moves you from SIRS to sepsis. And then sepsis with at least one sign of organ failure moves you to severe sepsis. And severe sepsis with refractory hypotension, defined as unresponsive to, and now fill in the blank. Is it a liter? Is it a liter and a half? Is it 2 liters? It depends on the study, but this would move you into septic shock. Okay? And mortality goes up. Okay? This is not my slide. I stole this from a colleague who got it from a drug company, so it's like tainted 3 times over. But I'd like to focus on the lower percentages here rather than the higher ones. Okay, in the 10 years ago, 15 years ago, 90% might have been, at least in some trials, the mortality at the far end here, septic shock. Now, 30 to 40% is more common. Okay, and that's, I think, because we do a better job. We're going to discuss what that better job is, but I think we do a better job in our maintenance. Getting antibiotics in early, okay, getting fluid resuscitation started early, pressors if they're needed, and it's always catecholamines just before vasopressin. And we'll discuss why vasopressin at all in the last part of this talk, as I mentioned. Don't memorize this. It's just a list of all the things that go into a terminal event, which is refractory hypotension, multiple organ failure syndrome, and death. And attempts to intervene at a variety of levels have all failed. And whether it's horse out of the barn, by the time you get to this point, it's too late, or whether what we have are just blunt instruments. And when you start mucking around with nitric oxide, you actually do a lot more harm than good because it's general rather than specific, located in a specific area that's having a specific problem. It's unclear. But at any rate, none of these things have really panned out. Quick background on vasodilation. This is, again, just a reminder of material from your first semester as a medical student. But whether or not a blood vessel dilates depends on the condition of its vascular smooth muscle. And this is a cartoon representing vascular smooth muscle. And we see the balance between myosin and phosphorylated myosin. When phosphorylated, it goes on to vasoconstriction. Dephosphorylated in favor of vasodilatation. This is the balance between a kinase and a phosphatase. Myosin light chain kinase is a calcium calmodulin dependent process. And that calcium comes from calcium stores, but also from voltage-gated calcium channels. And these are mobilized by the vasoconstrictors, norepinephrine, angiotensin II. On the other side of the equation, we have vasodilators. We have atrial natriuretic peptide, which binds to a particulate guanylate cyclase that increases cyclic GMP. Also, there's a soluble guanylate cyclase activated through nitric oxide, and a cascade that eventually results in phosphorylation of the phosphatase, and this regulation provides us with vasodilatation. Also note that the membrane has a polarization, and there are potassium channels in this membrane, a so-called ATP-sensitive potassium channel. And if that channel is open, then this membrane is hyperpolarized, and then the voltage-gated calcium channels don't open. Okay? So there's also a membrane potential element to this. And so what's the story here? First of all, a failure of vasoconstrictor mechanisms is a hallmark of septic shock. And moderately severe septic shock, and let's not get into exactly what that is, but terminal is the patient doesn't respond to anything at all. Okay? So someone who's moderately severe, you might expect to see something like 3 times the dose, giving a third of the effect, right? It's a full log order shift. And as things get worse, this gets worse. But the problem isn't just the failure of vasoconstrictors, it's actually the full-throated activation of the vasodilator mechanisms. And so nitric oxide is elevated. Atrial natriuretic peptide is 10-fold increased from baseline. And KTP channel activity is increased. And so the membrane is hyperpolarized. And so the voltage-gated calcium channels stay closed. So you don't get the calcium, you don't get the vasoconstriction. So all these mechanisms for vasodilatation are activated. they are contributing to the blunting of the vasoconstrictor mechanisms. This is why the vasoconstrictor mechanisms aren't working. What can one do? One question is, can we circumvent sepsis? And I didn't even bother showing you any papers after this. We'll just talk about it for a second. The critical way would be to do something like control a factor that predisposes to infection, okay, as a concept. There was a paper back in New England Journal 2001 by a group in the Netherlands who looked at the possibility of controlling blood sugar. And this intense control of blood sugar, keeping it down in the 110 milligram per deciliter range, worked miracles in a surgical population. Attempts to show this in medical populations have failed, and in their system where they had study nurses and had lots of intensive monitoring, the risk of hypoglycemia was kept under control. When it's tried in regular hospitals under regular circumstances, the risk of hypoglycemia is actually quite high. So we've sort of split the difference, even though there's only the hint of a rational basis for it. Okay, and the splitting the difference is let's control glucose a little better than we used to, but not as tight as the Vanderberg group says you should. And that's pretty much where things stand. Okay, so there is no hard and fast treatment that one should engage in aggressive glucose control. Okay, it doesn't seem to pan out particularly well. Certainly, it did not have a mortality endpoint in medical ICU population, and the results in surgical populations have recently been mixed. Broad-spectrum antibiotics, post-pan culture. This is something that absolutely makes a difference. Okay? And this is a metric for performance. And so in the ED, on the wards recognizing infection, the time it takes, medical team, the surgical team, the OBGYN team, whatever team you're part of, okay, to recognize what's going on and get the patient cultured and antibiotics in is really critical. It's uncommon, almost unthinkable that we couldn't get blood cultures. There are questions when you're concerned about meningitis and you're having a hard time getting a lumbar puncture, whether you should hold up the antibiotics for the lumbar puncture? No. Okay, but there's no reason why we can't spend 3 minutes getting a blood culture. It may have to be done through an arterial stick. If you're dealing with someone who is a venous vasculopath and has no vessels, you just can't get it, then you can do a radial artery. Early goal-directed therapy is probably why we are doing so much better in terms of mortality, and why that 30 to 90% range is now closer to 30, 40 than it is 70 to 90. Okay. And now the person who did this was, not that the name means anything to you or should, but Emmanuel Rivers. But he was a genius and fearless. So board certified in both internal medicine and emergency medicine. He took treatments that had resulted in increased mortality in each area. So goal-directed therapy that was and early therapy that was in goal-directed. Each is fatal. You put them together and you get an improvement. It was such a terrible problem that he was justified in throwing the kitchen sink at it. So the underlying hypothesis was improving tissue perfusion. If you can improve tissue perfusion, you would decrease mortality. So how do you improve tissue perfusion? Well, first of all, you make sure that early sepsis becomes fluid resuscitated sepsis. So you start giving volume early. What kind of volume do you give? You give water that goes into cells, right? A lot of it. Right, so you give saline, and you tank the patient up. How do you know if you've given enough? Well, you could look and see whether or not the periphery is extracting a lot of oxygen. If you're not extracting a lot of oxygen, then you're well perfused. If you're extracting a lot, then you're hypoperfused. So you could look at something like a central venous O2 sat, okay, as a way of getting a glimpse of whether you've completely oxygenated the periphery. So he advocated that. That required a central line placement. So the ante's being up, giving fluid, potentially 4, 6, 8 liters of fluid, okay, in 6 hours. So a lot of fluid, putting in the line. if things aren't perking up with the fluid, maybe the heart's not functioning well. Maybe there's a cardiogenic component. Your patients aren't simple. They don't read the books. They don't have just one thing. They could have many things, especially a patient who's older. Okay? So an elderly patient maybe has had a silent MI or two. As you start to give all that volume, the heart starts to dilate. You expose a defective left ventricle. Okay? So you would then, having tanked the patient up, and you'd know you would tank the patient up because you'd see that the central venous pressure was now in the range of 12. Okay? Then you would give dobutamine. And if the patient had a low hematocrit, you would transfuse the patient up to a crit of 30. The next decade is spent contesting each of these little interventions to see which ones are really necessary. Okay? And the distillation of all of that is actually the handout I gave you, which for those viewing at home, you'll talk to Garrett and get something to you. It's not critical, but it gives you a glimpse of how patients are actually managed. And this is just a flow chart saying what you're going to do and when, and how quickly you're going to do it. And the goal is to do it much faster than 3 or 6 hours. But you've got to start somewhere. And so this is where things stand here. And this is an example. And so here, instead of doing central venous pressures, we do lactates. Okay? So if you remember one thing today, it's check lactate if you have a suspicion that your patient could be in the axis of sepsis, heading in from SIRS and going in the wrong direction. Blood pressure might be stable, but things aren't looking quite right. The respiratory rate's up. Patient's tachycardic. Okay? You've got an elevated white count. Heaven forbid, a left shift of anemia. Check lactate. And if the lactate is elevated, even if these other things haven't hit yet, that's enough to move you into the realm of concern. Okay? Obviously, low blood pressure should also get your attention. And it doesn't have to be a shock level to get your attention. Okay? If it starts to fall below baseline, your blood pressure should start to rise. So this was the Emmanuel Rivers' original paper, and we see here CVP of 12 was the goal. The central venous O2 sat greater than or equal to 70%, and blood pressure greater than 90%. And you would do what you had to do to get this. And then if you couldn't, then you'd start adding pressors. And you begin with, in his study back then, catecholamine pressor. And it had a great effect. Here we see the mortality and standard therapy 59, early goal-directed therapy 38. Now, if you do a Google stalking of early goal-directed therapy, you'll see there's a paper in the New England Journal in the last year that quibbles and says, oh, early goal-directed therapy is not necessary. But when you look at the groups, they all got almost exactly the same amount of fluid. And it's just the case that our practices have changed, and physicians are appropriately heightened to the concern. And so if you're giving fluid early, then you don't need necessarily to do all the little things that Rivers did. And that's why I think we're now down to measuring lactates, giving fluid early, measuring lactates, and documenting that the lactate's falling as you're giving the fluid. And that lets you know that you're going in the right direction. Also, we might get a cardiac ultrasound, a cardiac echo, just to make sure the ventricles are filling, that there isn't something going on. You don't have a big dilated ventricle. I mean, again, you might get a hint from the chest x-ray, but just in case, you can check it. So the little things you can do that aren't invasive and that will allow you to manage your patient without the risk of complication. But suppose things don't go exactly well, and despite all the fluid that you're giving, you find that the blood pressure is still low. Do you give a pressor? And the answer is yes. What do you give? And the data for this is really not fantastic. So here's a prospective observational cohort study looking at patients in septic shock. And they looked at which pressor had a favorable outcome. Well, the bias in this kind of thing is gigantic. But at any rate, norepinephrine, they did better. Others, they did worse. Of course, maybe they got others because they were doing worse. Okay, you just don't know what's going on here. But this is the level of the data that says norepinephrine. What else could you try? So you could try renal dose dopamine, okay, dialed up to now be an alpha level, so it's no longer renal. As you are dialing it, it goes to beta range, it goes to alpha range, and at alpha range, that's fine. it does seem that there's an increased risk of ventricular arrhythmias as you dial up dopamine. So we don't use dopamine for this purpose. Okay? Our opening suppressor at this institution is norepinephrine. Okay? One could also go the other direction and say, okay, what about phenylephrine, a pure alpha agonist? And it is likely the case that the beta action of norepinephrine is beneficial, that there is a benefit to having a little cardiotonic effect. And so again, we at this institution don't. The institutions that use phenylephrine often use phenylephrine plus dobutamine. You might as well use norepinephrine. Okay? But that's the balance of this. It is not grade A evidence-based medicine. If you're going to give norepinephrine, how much should you give? There are a number of studies in the last year. There's another one published sort of like this. But it's designed to look at maintaining patients at sort of low, medium, and high pressure. And the question is, would your patients be better off if you jacked up the pressor agent? In general, the answer is no. Okay? Occasionally, some study will show that renal output actually increased on norepinephrine. But I think the consensus of all of the studies, the consensus of nephrology's reading of the studies would be that you don't get an advantage in getting higher pressure, okay, which is measured in a large vessel, okay, by cranking up norepinephrine, which is constricting the arterioles leading into the organs you want to perfuse. Okay, the actual organ perfusion pressure will not be materially benefited, okay, if you got there through norepinephrine. So generally not recommended. There can be doubts in your patient with a blood pressure of 200 and is now down at, and now is being maintained at 90 on pressors. You know, would 120 be better? But that's one of those things that there's no study to prove it, and you'd be left with an N-of-1 experiment in the ICU with your patient. Okay? And usually that's an experiment that's not done. Okay? But as you'll see in a few moments, if you give something like vasopressin, where pressure does rise, in the setting of that pressure rising, you could observe. And if things look more stable with a higher pressure, then you might leave it there. Okay? But that's an experiment, again, N-of-1 experiment, which is, in fact, the proper mode of practice. So if someone hasn't said this to you already, it is how you will practice medicine. Every patient, every time you give a drug, no matter what the data is for it, for that patient, it's an experiment, and so you have to treat it like an experiment, watching very carefully to understand the results. The net of all of this is that none of these markers, whether it's lactate or gastric mucosal PCO2 as a perfusion of the mesenteric circulation, none of these things showed a particular benefit. And so we don't do this. So we run a systolic of 90, a mean in the 65, 70 range. This is just for your review. It's a list of pressors and what it is that they do, and whether they are vasoconstrictors, whether they have some vasodilatory component, what are their cardiac effects in terms of heart rate or contractility. And you see the dysrhythmias are a little higher for the dopamine, and vasopressin is a constrictor in certain circumstances and has a minimum dysrhythmic potential. And I actually think this is closer to 0, but at any rate it's listed as 1+ in Cecil's. I just put these so that you can compare. This group is would be the group of vasopressors. These are not vasopressors, these are inotropes. Okay? These are increasing contractility. They may actually be vasodilators. Okay? Minimal vasoconstrictors, except dopamine as you start to dial it up into constrictor range. If you had a patient who needed an inotropic agent, but they were in profound vasodilatory shock, you might actually start with dopamine. Okay? And then dobutamine. And the last thing you'd add is milrinone, because milrinone is a 3+ vasodilator. 50% of the positive, the inotropic effect of milrinone is due to afterload reduction, secondary to vasodilatation. And about half is due to a direct increase in contractility. Okay? That's why it's called an inodilator. I summarized and actually, for those of you who end up not getting a handout, this is the summary of it. This is the little module we give to medical house officers. So they have it on an index card so that it primes them what to do. And then what I handed out was the actual breakdown of the flow sheet for nursing implementation. And the critical thing is sending lactate immediately, looking at the blood pressure, making decisions based on lactate greater than or equal to 4. Mortality rises with lactates rising to 4 and higher. Mortality just goes up. A few words on vasopressin. And if you do take the 4th year course, don't say, I covered all of this today. That's one of my evaluations. We did this already when we were first years. This is the neurohypophysis, and vasopressin is synthesized in paraventricular and supraoptic nuclei. It's released in response to osmostimulus, but also baroreflex-mediated secretion. Okay, you've seen this slide, right? This was earlier in this course. And you've seen these. This is rising from the set point, plasma osmolality. We see vasopressin rising. And we see the end organ response, the kidney, and this is the V2 receptor. And as vasopressin rises, urine osmolality rises till finally it plateaus at the concentration of the medullary interstitium. But as the name suggests, vasopressin, there's some connection to blood pressure here. And this is percent decrease in mean arterial pressure. And this is plasma vasopressin. And it rises now on a log scale, level of 100. You can get levels of 300, 400 picograms per ml due to a non-osmotic stimulus to ADH. All it takes is a tiny little bit to maximally concentrate the urine. But look how high this thing can go, and I can tell you can get points up in here. Vasopressin is an incredibly potent vasoconstrictor. And this is percent reduction in lumen diameter. This is an efferent arteriole. This is a negative log scale. This is vasopressin. This is norepinephrine. 2 log units. So vasopressin is 100-fold more potent than norepinephrine on a molar basis. 100-fold more potent. Okay. In vitro. Interestingly, this is the first administration of vasopressin to human subjects, Grubeel and Glendy, JCI 1940, and it's a continuous infusion at a dose that would give a circulating level of hundreds of picograms per ml. And blood pressure is not changed. So in vitro, isolated vessel, intensely vasoconstricting. Okay? And I could show you many other types than the efferent material, but intensely vasoconstricting. Give it to a whole person, normal subjects, and blood pressure doesn't rise. It's not that this patient is clamped down so much and cardiac output has fallen so low. Okay? Cardiac output may go down a little tick, but this just doesn't seem to be engaging in the vasoconstriction. In fact, there was no reason to give vasopressin to normal human subjects. It was available as an injectable for 50 years, okay? Because it doesn't raise blood pressure. It could be used to constrict the splanchnic circulation in the case of variceal bleeding. So GI would use this. Patients who have cirrhosis with variceal hemorrhage. Okay. Wouldn't raise the blood pressure very significantly at all, but would constrict the splanchnic bed and decrease hemorrhage. Only reason to give it for a vasoconstrictor effect, not a pressor effect, okay, because it wasn't having a didn't raise pressure. And then I saw a patient, I was asked to see a patient who had just apparently crashed into septic shock and was in septic shock and was on catecholamine pressors and blood pressure fell, but this was just too abrupt. And they wanted me to dialyze the patient because the patient had end organ response, kidney failure, wasn't making urine, and I was doing the nephrology consult service. This seemed too abrupt. And the story was that this patient had had cirrhosis, variceal bleeding, had gotten some vasopressin for splanchnic constriction, was stable, and the nurses, after 2 days of no hemorrhage, turned it off, which is what you do per protocol. When they turned it off, blood pressure plummeted. And what had happened was this patient had become infected and was septic, but wasn't in septic shock until the vasopressin was turned off. Okay? So I filed that away, that maybe, oh, and by the way, I got them to start vasopressin, and when they did, blood pressure rose. I filed this away as maybe it's the case that sepsis, the condition of septic shock, transforms vasopressin from a non-pressor to an exceedingly potent pressor. But when I also read some literature, it indicated that vasopressin could also decrease cardiac output. And even if it decreased it just a little, I thought in the hyperdynamic state of sepsis, to decrease cardiac output could kill some number of patients. So I was afraid to give it. Then this patient came along, and we'll stop in 2 minutes. This is a 53-year-old man with intractable ventricular arrhythmias who crashed to bypass. It was at a time when we were starting our VAD program, and so he was in the CCU. They did chest compressions all the way to the OR, cracked his chest, put him on an RVAD and an LVAD as a bridge to transplantation. So now you see the ventricles hanging at the bedside. You can see them filling, and everything looks good. His blood pressure is stable. Unfortunately, in the crash to bypass, he became infected. His blood pressure trends down and had been in the 120s, 130s, and it's drizzling down. As it drizzles down, he gets started on catecholamine pressors, norepinephrine and epinephrine. Now, I get a call from the cardiothoracic surgeon saying, any tricks for managing patients like this? And when I heard the story, I said, well, in fact, yes. Because now this patient has no heart, right? So I can't do harm. And the ventricular assist devices are afterloading sensitive. So if you were to raise the patient's blood pressure, that would not decrease VAD flow. Okay, you have to get above 170 to do that. So we knew it was safe. So I suggested they start vasopressin. And they did. And here we see vasopressin, and blood pressure rises. Now, the PA is concerned there's too much blood pressure, so he turns the vasopressin down, eventually has to turn the catecholamines on. The surgeon returns, his face is this color red, says, get that thing back on. And when he does, blood pressure rises. And a few quick observations. First of all, there's more blood pressure in those periods where vasopressin and catecholamines are administered concomitantly. It's well known that vasopressin and catecholamines act synergistically in vitro. But it's true that vasopressin by itself doesn't do a bad job with pressure. Here it's 100, 110. You could say this is a function of dose, dial this down, dial that up, and we could raise this and lower that. Let's look at end organ response. What does the end organ feel? Well, what's the most important end organ? Kidney. So let's look at the urine output. 0 to 5 cc's an hour, getting no diuretics after time 0. And lo and behold, the urine output jumps up on anti-diuretic hormone. Right? That doesn't make sense. How could that be? Then it comes down. Then it goes back up again when vasopressin's on alone, and it's at 50 to 60 cc's an hour. Serum creatinine, slowly rising in this phase, is now slowly declining in this phase. Okay, finally, if the surgeons weren't concerned about implementing a therapy based on a rumor, I was concerned about starting the rumor. And 0.04 is 1/10 the dose given to the cirrhotics with bleeding esophageal varices. I figured I'd give 1/10 the dose and dial it up slowly to give the minimum dose to achieve the desired effect. Instead, 1/10 of the dose gives these large swings. Did it on 10 patients, and they're in vasovagal septic shock, and blood pressure rises, cardiac output does come down a tick, but it's still quite elevated. So we're not putting this patient into cardiogenic shock. These patients don't have VADs. Resistance rises very significantly. 6 out of 10 come off catecholamines. So this appears to be reproducible. First time we try and turn it off, blood pressure plummets. Okay. Try and turn it back on, blood pressure rises. This is 1 cc on the IDAC, the dilution we were using at that point. How could such a tiny dose have such a large effect? Right? It must be that the endogenous vasopressin, which should be released by low blood pressure, is deficient. Right? And that's why the receptors are unoccupied, and a little dose gives this big effect. We can test this. So this is a group of 19 patients in sepsis compared to 12 in cardiogenic shock. And the septic shock patients all cluster in AVP at the bottom of the register. In cardiogenic shock patients, there is some overlap. This is profound and prolonged cardiogenic shock. It starts to look a little bit like sepsis. Right? And so I include more material, but this is a good place actually to stop. This has now become the standard of care in the ICUs throughout most of America and Europe. And I was just in South America, and they're using it down there. There is a randomized, placebo-controlled trial that gave mixed results, the so-called VAST trial. Seemed to be better for patients who had less severe sepsis and those with more profound sepsis. And so there's another study that needs to be done. That VAST trial has not been dispositive, hasn't stopped people from using it, hasn't mandated its use, but it's now part of our formulary and it's part of the sepsis protocol that I handed out. You always give vasopressin second. You give catecholamines first because you want to make sure your patient is in vasodilatory shock. You do not give vasopressin to a patient who's hypovolemic or cardiogenic until you've cured the hypovolemic and the cardiogenic component. Because if you do, you will decrease cardiac output even more. It turns out the patients who see drops in cardiac output are the patients who are not adequately hydrated, not adequately filled, okay, or have a decreased myocardial function and need an inotrope. Okay. The urine output goes up. Why? Because you're actually improving GFR. You improve perfusion of the kidney. Why does the antidiuretic hormone not lower the urine output? Because it's antidiuretic effect. First of all, within hours, you're isospheniuric. So you don't respond to vasopressin anyway. But insofar as you responded to vasopressin, the low levels of vasopressin that you see in the normal subjects, this is enough to maximally concentrate the urine. Okay? 5 to 7. So you've already got it on board. Adding more doesn't change things. The only thing, what it changes is actually the perfusion of the kidney. Vasopressin does not constrict the afferent arteriole of the kidney. It only constricts the efferent arteriole. And since it only constricts the efferent arteriole, it maintains glomerular pressure. It doesn't constrict the afferent. So it favors, whereas norepinephrine constricts the afferent. So all these little facts that lead to the conclusion that vasopressin is actually the ideal pressor in terms of renal perfusion. Thank you for your attention. I'll leave you in the hands of Dr. Radhakrishnan.
Do you want to take any questions?
Want to ask any questions?
That's a threat.
Doubts, denials? Yes, we have more handouts. Dr. Garrett has filed. Some have them. Oh, your road didn't share with you. Yes. Great question. So it looks like predominantly the gland dumps its stores early. Okay, so the levels in acute sepsis in animal models exceedingly high, and then they plummet within about 90 minutes. Okay, and so studies were actually done in the 70s looking at the delay in synthesis of more vasopressin. Because say, why don't you release more? We've done studies dissecting out neurohypothesis, and its immunoreactivity for vasopressin is greatly reduced. There's also data, I should say, that elevation in nitric oxide inhibits vasopressin release. So there may be a second mechanism. But then why don't you make more of it to the extent you're depleted? Messenger RNA levels spike 9 hours later. And that's in an animal that's not in persistent shock. So we think it's just you dump the stores, you don't make more. There's a vasopressinase in blood. Liver also destroys vasopressin. And it's why we don't become water intoxicated when we get to the oasis and we slake our thirst. You know, your high vasopressin levels from your hyperosmolar state go away very fast. You know, it's part of the intrinsic homeostatic regulation. The vasopressin we give is chemically identical to the endogenous vasopressin. So when we watch, you know, the drug we give get chewed up, that's the same rapid rate of chew up that occurs with the endogenous hormone. Very good. Microsoft Teams.
Do you have a lavalier mic?
Oh,
This will be giving a talk from your office. It's like those election candidates, right?
speak up for the microphone. Okay.
Actually, it makes sense. I didn't even think the dawn would switch. I called the secretary and said, and then go into action. This is what last 3 days. Seriously, every person is very good. Small yourself. I would say definitely uncomfortable. That's what I mean. So it doesn't. This is not being changed. And people, look at the difference times. You have to deal with the customer. You can't bring this here to there's overwhelming sense amongst all the spoke leadership and small businesses. They're all dissatisfied. It's just because the way it's set up is there are also a couple of sessions. Heavy. See, the thing is, you don't want to go into just talk about there's no way this entire AFP and this you don't know what happened to that. But you need pharmacology of hepatitis, you need management of target organisms. And that actually put into a program. It's not physiology. And you try to make something, like forcing another physiology, it's very normal. Secretly, it's very hard to figure. There's a lot of things that it's sounding basic. Like, so it's all about fixing. No, and you should also that talk with me. He's a wonderful speaker. He just was clear on that. And I think all of it, I get this one sort of farmer policy. They talk about the whole SAP and all of it. Really so big.
Okay, let's settle down, guys. Part 2 of today's lecture topics. Okay, can we settle down, please? All right, this is going to be on the management of what we have learned this far, insofar as patients coming in with an assortment of fluid and electrolyte problems. So we'll go through the concept of volume distribution, which is very important if you give any drug. And intravenous fluids, remember, is a drug. Then I'll take you through what choices are available, and then we'll go through clinical examples of the types of fluid depletion states that you'll encounter in clinical practice from a pathophysiological standpoint. I have no conflicts of interest. There's no money in salt and water. Okay, so if you take the distribution of water, okay, or for the matter of fluid, if you take the body right here in this box, right, 60% of this body weight in males is fluid and 50% in females, which reflects the proportion of muscle to fat. If you take the total body water here, it's divided into intracellular and extracellular. Intracellular is 2/3 of the total body water, and extracellular is 1/3. And there's one notable difference in these two compartments. Water can go back and forth very easily through the aquaporin channels, but sodium is limited to the extracellular fluid. So if you give a solution containing sodium, it will not distribute equally through intra and extracellular compartments. It will stay in the extracellular compartment. Whereas you give water, if you drink water or give water IV through dextrose, it's going to go through the total body water compartment and will not respect these boundaries. So that's a very important point I'm going to emphasize again and again. When you administer a certain kind of fluid, you need to know where it distributes. If you further look at the extracellular fluid compartment, you can see there's a further subdivision. There is the intravascular compartment, which accounts for 1/4 approximately of this extracellular fluid, and 3/4 is in the interstitial extravascular space. The capillary membrane is not a barrier to salt and water. It equilibrates very easily across the space. So if I give somebody water or a salt-containing solution, it's going to very rapidly distribute across the intravascular and the interstitial compartments in proportion. Clear so far? Yeah. And then there's this concept compartment. It's called third space. And what is this? It doesn't really exist in a normal physiological condition. But when you have a disease condition, it is associated with sequestering of these fluids into this so-called virtual space that is now no longer in dynamic equilibrium with the extracellular compartment. And I'll give you a few examples. If you take a patient with intestinal obstruction, so you have intestinal fluids entering the lumen of the small bowel, but there's a blockage further down. So this fluid is not going to go back into the extracellular compartment where it's coming from. So you basically have the intestinal transporters pushing fluid into the lumen of the intestines. So normally it gets reabsorbed later on in the colon and distal ileum, but if there's a blockage, say mid-ileum, it'll just back up and you'll vomit it out. So you're going to lose all this fluid to the to the outside at the expense of the extracellular fluid compartment, which will get slowly and slowly depleted progressively until you infuse it back intravenously. It's because you can't take this in orally. It's just because you're not absorbing it, you're just barfing it out. So you have to give this intravenously. So that's the third space. It doesn't really exist in real life unless you're diseased. Other examples, severe pancreatitis. Where does the fluid come from? Extracellular space. Where does it go to? Into the peripancreatic tissue and the abdominal cavity. How about peritonitis? Same thing. You have inflammation, disruption of your capillary membrane barrier, and lots of leukocytes, lots of albumin, lots of salt and water, all coming from the extracellular compartment. If you take a patient with an IVC obstruction, there's a buildup of hydrostatic pressure below the level of the IVC that's obstructed. And because of this hydrostatic pressure, fluid leaves the capillaries in your legs and your thighs, and you get this massive edema, which occurs at the expense of extracellular fluid. Same with capillary leak syndrome. Dr. Landry gave a talk on septic shock. In septic shock, there's release of cytokines that causes vasodilatation and disruption of the capillary membrane. So you get leakage of intravascular and extracellular fluid into the tissues, right? So patients get very puffy at the expense of extracellular fluid, and they go into shock, which is worse because of vasodilatation. These are all examples of third space. Burns. Your fluid is seeping from your skin to the outside. You lose the nice barrier that your skin provides in preventing loss of this fluid to the exterior. So these are all examples where fluid is being removed from the extracellular compartment into a space that is not in dynamic equilibrium. It's a one-way efflux of fluid into these spaces. So if you take water balance, okay, so we all drink water, okay, somewhere between 1 liter to 1.5 liters. And the only insensible loss is almost fixed if you're in an ambient environment that is normal, but it can go up. So lungs and sweat, you can lose increasing or decreasing amounts of fluid. And the balance goes into the urine, which is 1 to 1.5 liters. So you need a certain minimum volume of fluid, which is depending on the osmolarity, the max osmolarity of the urine, which is about 1,000 to 1,200. So most of us need at least 500 mils of volume to get rid of your toxins. Okay, but beyond that, it's just basically wasted. So let's talk about volume of distribution. Okay, and just to see what happens to the volume of each of these spaces in a hypothetical 70 kilogram male. So here, if you take 60% of body weight as total body water, we get 42 liters. So a 70 kilogram male, 1 liter is equal to 1 kilogram, is approximately 42 liters of water. Of these 42 liters, 2/3 is in the intracellular space, which is approximately 25 liters, and then 1/3 is in the extracellular space, which is 13 liters. And then you divide that further, the blood compartment, intravascular, is 1/4 of this 13, which is approximately 3 to 4 liters, and the rest is in the interstitial space. So this is how the volume is distributed in this hypothetical 70 kilogram male. So before we launch into treatment, we need to get an idea of how much fluid we need to give back, and most importantly, what kind of fluid are you going to give back to the patient? And this depends on which of these compartments are going to be affected predominantly, and also we need to keep an eye on other acid base and electrolyte and nutrition issues, which can be also concomitantly corrected with the fluids that you're going to give this patient. So if you look at what's available, there's a huge variety, and sometimes you might say, oh, this is more than what we need. But each of these fluids have a very specific function. So on a broad classification basis, on the left, there are the crystalloids, and on the right, there are the colloids. So let's deal with the colloids real quick. So the classical example of a colloid is albumin. So we all carry approximately 4 grams per deciliter of albumin in the intravascular space, and it's required to maintain the osmotic gradient, which draws in water, salt and water from the interstitial space back into the lumen of the of the blood vessels, right? So if you were to resuscitate somebody in a very speedy fashion, we need some fluid that's going to stay in the intravascular space. Supposing you're in the middle of a war situation, right? And you lose your hemorrhaging blood and you go into shock, okay? The quickest way to bring back blood pressure is to use a fluid that's going to stay inside the intravascular space. The best fluid is blood. Blood's not available that commonly because you have to cross-match it and do all these tests to make sure there's no reaction. So you use a bland fluid. The most commonly available fluid in the hospital is albumin. You could also create a synthetically made fluid, which for example dextrans. These are all carbohydrate polymers which are osmotically active, so they stay inside blood vessels, they don't leak out. And also other compound carbohydrates called heterostarch. And these are also available if you need them. Albumin is kind of expensive, these are less expensive. But these are all designed to stay inside blood vessels and rapidly expand plasma volume in the setting of, for example, hemorrhagic shock. But on the left, there are crystalloids, okay? And I'm going to just show you the three kinds of dextrose in water. Dextrose is metabolized almost within a few minutes to an hour or two. And you're left with essentially water. So any dextrose-containing solution without any of the sodium or potassium is essentially free water. And we go up on the concentration of dextrose depending on the nutritional needs. If someone is hypoglycemic, you don't want a large volume of water. You just want a small volume of water and lots of dextrose in that volume. So you have 50 grams per deciliter, D50W, as being the fluid of choice. Where someone has lots of hypernatremia, i.e. dehydration, pure water loss, you can just give D5W because you don't need the extra amount of sugar, but just all this patient needs is a lot of water, right? So that explains why there are varying concentrations of dextrose in water. And then we go into the saline-containing solutions. So isotonic saline mimics the concentration of sodium in the extracellular space, okay? So if you were to get a loss of extracellular volume, the best way to replete it would be to give something that's similar to extracellular volume. And the two flavors are isotonic saline, and the last is the so-called Ringer's lactate, which contains a little bit of bicarbonate in the form of lactate. And there's a lot of controversy about which is better, but they're both equivalent in terms of what they're doing. They're repleting the extracellular compartment with a tonicity which is very, very similar to the extracellular compartment with sodium, right? So that's the most important fluid that we need to know here. We can also get half normal or quarter normal sodium chloride. And why would that be used? If someone has a lot of ongoing losses, for example, GI losses, and their proportion of water loss to sodium loss is a little higher, you may want to give a little bit of water, a little bit of sodium in this solution. And those have to be tailored according to the patient's clinical condition. But you don't normally need that solution in the setting of acute resuscitation. And then we have hypertonic saline that we use in patients with hyponatremia. So someone with SIDH comes in seizing because of cerebral edema. There's expansion of the brain volume. You want to restore the extracellular osmolarity fairly quickly with IV bolus of hypertonic saline, which brings up the serum sodium, and you get shrinkage back towards normal of brain cells. So, and there are combinations you can use. Someone cannot eat or drink for a week because of intestinal surgery. You can give some dextrose and some salt. But the three key areas of this is you need, for a patient with a pure water loss, we need dextrose in water, right? For a patient who needs to be resuscitated quickly with intravascular expansion, you need a colloid. And for patients who have extracellular volume depletion, you need either normal saline or Ringer's lactate. So those are the three. If you can get these three concepts, we can always work on the subtleties of the patient to use the other fluids. But these three fluid types have to be firmly embedded in your understanding. If I give you a liter of 0.9% or normal saline, where is it going to go? It's going to go into your extracellular space and proportionally through the intravascular and the interstitial space, okay? So of this 1 liter, in the extracellular space, 3/4, 750 mils, goes into your interstitial space, and only 250 ml stays in your intravascular space. So, if you want to say restore 1 liter of blood volume that you've lost, you need to give 4 liters of normal saline, okay, because of this distribution. How about if I give you 1 liter of dextrose? And dextrose, remember, is free water because the sugar gets metabolized. This goes through the total body water, and the proportion is exactly the same. So 2/3 goes into cells, 700 ml, 300 stays outside cells. And of this 300 ml, only 75 ml, 1/4 of 300, is intravascular. So would you use this as a plasma expander in someone who's in shock? Never, because only 1/12, 75 mils of 1,000 ml, is going to expand your plasma volume. So you need 12 liters to gain 1 liter of intravascular volume. So this is a very inefficient way to do this, and furthermore, you're going to dilute the fluids with this huge amount of water, which will cause a very precipitous drop in the serum sodium, right? So we never use dextrose in water as a plasma expander or to restore people who are in shock. So the best drug, therefore, would be albumin. And look at albumin, it stays in the intravascular compartment in its entirety. So 1 liter of albumin is going to stay, all of it's going to stay inside, as opposed to 1/12 of water and approximately 250 ml of normal saline. So this is a very important concept when you look at which fluid to use in which situation. You need to know the volume distribution of each of these fluids. Is there a difference in terms of outcome? So we have these fluids. Someone's in shock and we want to resuscitate them. Is it 4 liters of saline? Is it the same or worse than 1 liter of albumin? So we do a randomized controlled study. The outcome is the same, as long as you use enough volume to maintain blood pressure. Okay, so that's the key point, is that if you need to get the pressure up quickly, yes, use albumin, but if you've got a good large IV and you're infusing saline at 4 times the rate, you will get the same outcome. Okay, so conceptually, they're both the same in terms of efficacy to restore hemodynamic compromise to normal. So let's look at some clinical examples of how you would use these fluids and based on what the nature of the volume deficit is. Okay? So we spoke about this indirectly. Now we'll crystallize them further, and I'll give you clinical examples where you can actually use the kinds of fluid we have available in each situation. So someone gets into a road traffic accident and loses blood. The volume is going to come essentially from the intravascular compartment initially, and then over time there'll be movement of fluid from the extracellular space back into the vasculature. So there'll be a second wave of volume depletion. If you take a person who's got diarrhea or is third spacing into ascites, okay, you are going to get a drop of your extracellular space, and it's proportional to both intravascular and interstitial. So the whole space is going to contract simultaneously. If you have a patient who's losing water, and 2 examples are diabetes insipidus, you have no ADH, you're making a urine that's only water, or purely water, you're going to lose water out of proportion to salt. Okay, so your serum sodium is going to go up unless you're drinking it back. Another example is osmotic diarrhea. So you take a laxative which is osmotically active, you're going to be pulling out lots of water, a little bit of salt. So there's predominant dehydration rather than volume loss. And where does it come from? The entire total body water compartment. Okay? So these are the 3 categorizations of how you could lose volume, and it depends on the nature of the volume loss. Okay, so how can you diagnose this clinically, these 3 compartments? So if you take a patient who's lost blood, it's not subtle. You're losing blood, you can see it. It's either bad hematemesis or there's a history of blood loss, right? But since the intravascular compartment is a predominant manifestation, you will get signs of shock, which Dr. Landry referred to. Initially, there'll be a slight drop in blood pressure and an increase in heart rate. Your JVP will be collapsed, right? Your sympathetic system will rev up, so your extremities will be cool. You'll sweat, especially in your armpits. Your mucous membrane is going to be dry because of vasoconstriction. And finally, if you are in an ICU with a Swan-Ganz catheter, you'll document that cardiac index is down and your filling pressures, as measured by CVP, central venous pressure, or the pulmonary capillary wedge pressure, are going to be low. So there's signs of volume depletion. There's signs of shock that defines intravascular depletion. If you go further into the next example, so you have lots of diarrhea, okay? What's going to happen is you're going to proportionally lose intravascular and interstitial fluid because they both are in dynamic equilibrium. What's going to happen essentially is that you lose skin turgor, which looks like this. If you pull up your skin on the dorsum of your hands, it won't snap back. Okay? That implies that there's interstitial pressure is low. Your body weight will drop, and that's a very sensitive way to tell what's going on. And then finally, when you lose enough, you will experience exactly what the guy with blood loss experienced, which is hemodynamic compromise. And then finally, what happens when you lose just water? So a patient with diabetes insipidus who's making 4 liters to 5 liters of urine a day of water will get hypernatremic, will get hyperosmolar, and it'll drive thirst. So that's the predominant compensation to this water loss. And you'll drink it up until your osmolarity comes back to normal. But if you don't drink it up, then your serum sodium is going to start rising. Okay? And this is water, guys, okay? So let's take a look at how much of extracellular volume you need to lose and what is each degree of loss going to translate to in terms of clinical manifestations and kidney function. So you take 10% of extracellular fluid. For example, we saw that we can go back to the example of the 70 kilogram person, right? Just to give an idea. So this person has 13 or 14 liters. So if you lose 10%, which is about 1.5 liters, 20% is about 2.5 liters, and so on, okay? So just to give you an idea of how much volume the ECF contains, and what would a 10, 20, and 30% loss translate to. Okay. So 10% loss will be about 1500 ml if it's a 15-liter guy. So there's a little bit of thirst, but the urine volume starts to drop. Creatinine hasn't changed yet. So the patient may be dizzy, may be experiencing a little lightheadedness when they stand up. It gets very pronounced when you lose 20%, which is about 3 liters of ECF volume. Now you get postural changes, okay? Tachycardia, orthostasis, apathy, and the skin turgor is pronounced, loss of skin turgor. Urine volumes begin to drop to clinically significant levels. When you lose 30%, which is 4 liters, you're now going into shock because it's going to translate to 1 liter of intravascular volume loss. And you lost more than about a third of blood volume, of intravascular volume. So that's significant, and there's overt shock, and the kidneys essentially stop working at this point. So if someone's in shock, the amount of volume you need to give to the ECF, extracellular volume, is about 4 liters. Okay? And if you do the math in reverse, that equates to 1 liter of albumin or 4 liters of saline. 1 liter of albumin goes in intravascular, 4 liters goes into the intra and interstitial compartment. So but that's how we measure the degree of volume loss based on clinical exam and kidney function. So clinical examples. This is a 25-year-old male who comes with massive hematemesis for an hour. He has history of peptic ulcer. He's diaphoretic. His skin turgor is normal. His blood pressure goes from 120 to 90 on sitting up, as his heart rate from 100 to 140. His serum sodium is normal at 140. So what is the nature of this patient's fluid deficit? So we had said that if you lose intravascular volume, right, the predominant effects are going to be hemodynamic, which is blood pressure, heart rate, and signs of sympathetic overactivity. His skin turgor is normal, so this is not yet, the fluid hasn't moved from the interstitial space into the intravascular space because there's not enough time. He's just lost a whole lot of blood. It's predominantly intravascular. And the fluid resuscitation you can choose. Ideally, it'll be whole blood. But while we're waiting, you can use IV saline. If you have a nice IV, 2 IVs, you're giving 1 liter an hour at least, or wide open as we call it. Or we can use albumin or head-starch, which are plasma expanders because they're colloid and essentially stay within the intravascular compartment. Now the question about hematocrit. So someone is bleeding acutely, there'll just be a quick contraction of the intravascular volume and the hematocrit's not going to change, right? But over time, what's going to happen is fluid's going to be mobilized from the interstitial to the intravascular compartment because of a fall in hydrostatic pressure, and you are resuscitating with saline, which is going to dilute the hematocrit, and that'll be a progressive drop. And we use that as a criteria sometimes for transfusion. So patient's blood pressure is back to normal very quickly with, say, 1 liter of saline, and the hematocrit's gone down by, say, 10% or 20%, but not below 8, the hemoglobin. Maybe we will choose not to transfuse unless the patient's really symptomatic or there's a high risk of ischemia because of compromised circulation in the heart or the brain. Okay, so that's another discussion. But the idea here is when the patient first presents to you, you don't have the time to give this patient blood. You want to get the volume as quickly up as possible, either by using a plasma expander or by using either Ringer's lactate or normal saline. We've spoken about shock, I think, but the downside of shock is organ dysfunction. So it's not just a drop in blood pressure. It's going to lead to a problem with organs. And the 4 classic organs are the kidney, which is very sensitive, the brain, especially if you're older and your small vessels are compromised, you'll get what's called watershed infarction. Between 2 territories, middle cerebral, anterior cerebral, there'll be ischemia and necrosis of the brain in that territory. Shock liver is patients with heart failure go into shock. It's the portal circulation and the systemic circulation are both compromised together, and it'll lead to damage to the liver. And then finally, ischemic colitis. Again, almost predominantly seen in older folks with compromised blood vessels. So, but these are the consequences of not having a blood pressure for a significant length of time. But the kidney by far is the most sensitive organ to this problem. There's also a time, so you can't wait too long. So if you take this dog and bleed the dog and you give back the blood within 2 hours, everything comes back to normal. But the same dog, if you wait for 4 hours, there's initial resuscitation, blood pressure goes up, but there's a phase of vasodilatation, which we call irreversible shock, where the dog doesn't get any better, and that's because of the release of vasodilatory substances like nitric oxide and cannabinoids, endogenous cannabinoids. So those were examples of hemorrhagic shock. Let's talk about diarrhea and vomiting, which is an example of what? Of extracellular volume depletion. This is a person, I'm tired of seeing medical students, we have peppered you guys with all sorts of diseases during this course. So a person comes back from a Caribbean vacation with severe diarrhea and vomiting, okay? You guys are below people until you pass. Just kidding. Okay. Sunken eyeballs, foreskin turgor, and dry mucous membranes. Okay? Blood pressure is low, patient has a high resting heart rate. Here the serum sodium is low, the potassium is low, bicarb is low. There's acidosis, and if you cast your experienced eye over the acid-base problem, you see that it's pure metabolic acidosis. So it's a complicated patient, isn't it? So let's parse through each of these problems and tell you what's going on here. Clearly there's a drop in blood pressure, so the intravascular compartment is compromised. We know the patient's history. It's salt, water, and bicarbonate loss. in the gut. So there's also a drop in interstitial volume. So they're both going down in proportion. Because where does diarrhea fluid come from? Comes initially from blood vessels, and then it's directly in equilibrium, the salt and water is, with extracellular compartments. So the entire extracellular space is contracting in proportion, both interstitial and intravascular. What else is going on here? The patient has severe hypokalemia. So you would expect in a patient with acidosis to have high potassium, but you have a low potassium, which means there's a tremendous amount of potassium loss also that goes along with diarrheal fluid. And finally, the patient's acidemic, low bicarb, because of a loss of bicarb in diarrhea. So there's a whole lot of things that are going on concomitantly that need to be addressed. Why is the patient hyponatremic? Because you're drinking what kind of fluid? Either water or something like Gatorade, which is hypotonic. You need to get salt and water back, not just plain water, in a patient who's this volume depleted. And why? Because if I just take pure water in the setting of volume depletion, your ADH levels are sky high, and you're not going to get this water out of the system. You need salt and water to resuscitate this patient. So we'll start initially with what? With sodium chloride to get the blood pressure back. And then we replete back the bicarbonate and the potassium. Okay? You can do it concomitantly, but the first and foremost aim of this experiment is to get back blood pressure so that your organs are not compromised. And then over time you correct the electrolyte deficit. And the way you can do this is give separately potassium chloride intravenously and mix bicarbonate with dextrose and calculate how much bicarbonate you need and slowly replete that while the potassium is being restored to normal. Because if we just give bicarbonate without potassium, there'll be a shift, further shift of the potassium back into cells, and patients will get a cardiac arrhythmia while the bicarbonate deficit is being corrected. So concomitant use of potassium and bicarbonate. Okay, complicated patient, but you have to parse through this is real, okay? This is not someone that's going to just come with one or second or a third problem. With severe diarrhea, they all come together. And what would happen if D5 is being used? The patient's already hyponatremic because your ADH level is sky high. All that's going to happen is you won't restore any of these other problems. You'll just make the hyponatremia worse. So you cannot drink Gatorade when you have severe diarrhea. Drink Chinese soup with rice, because glucose transporters will get activated in the gut. You'll absorb more sodium. You know this, right? You know this? What is the oral rehydration mixture used in cholera epidemics? It's got glucose, it's got salt, and it's got potassium. So basically mix salt in clean water, a couple of spoons of sugar, and salt. And that's the best way to make up your deficits. And you can use rice water, okay, that contains amino acids, transporter which brings sodium back in much more efficiently. You guys need to read up WHO oral rehydration mixtures. When you're out on your next Caribbean vacation, you know what to do. All right, let's go to the third example, which is hyperosmolar state. This is extremely common in the Allen Pavilion. The Allen Pavilion is a community hospital attached to Columbia, which caters to a whole bunch of nursing homes. Okay, so patients there are sometimes demented. They have diabetes. Okay, and now this patient's being shunted into the hospital because there's increasing confusion. So what's going on with this patient? You examine the patient. She's disoriented. Her blood pressure drops from 110 to 90 in the sitting posture. So there's a clear orthostasis, this decreased skin turgor. Her serum sodium is 150. The weight will become important later on, just hold on to that weight. The BUN creatinine is up with a high BUN to creatinine ratio. Her blood sugar is a whopping 1200. And the hemoglobin is 45. So honk if you know the answer. Anybody know the answer? Hyperosmolar HO, non-ketotic non-ketotic hyperosmolarity. So it's hyperosmolar state, but not in ketosis. Honk. Okay, I wasn't kidding. The answer is honk. Hyperosmolar, non-ketotic state. What's happening here? So this starts with a little diabetes, right? And a little diabetes means that if you exceed the threshold of reabsorption of glucose by the kidney, what's going to happen? You're going to get glycosuria. When you lose sugar in the urine, you drag with it what? Salt and water. More water than salt. If the patient's not eating and drinking, which is not infrequent in nursing homes because the care is sometimes not 100%, you will get a progressive loss of salt and lots of water. Okay, so your hypernatremia is explained because more water is lost than salt. There is some salt loss too, and that explains the orthostasis. But why has the sugar gone up to 1200? There is a little bit of loss of insulin, but the biggest problem is what do you need when your blood sugar goes up to prevent you from getting to levels this high? You need kidney function, right? So if you're so volume depleted that your kidneys are barely working, you're not going to excrete all this sugar. It's going to just accumulate. So this is a sign of what we call extreme volume depletion and dehydration. There are two concomitant problems going on together. You're losing lots of water, some salt, and it's leading to this whole pathogenesis of HONK, hyperosmolar non-ketotic state. How would you treat her? You got 3 modules that you're going to use. Okay, module 1 is restore intravascular volume, again with saline. So bring up the blood pressure. That's always the first directive. Okay, once the pressure is up, then you focus on the water deficit. We use a calculator for the water deficit. Just ignore what I've written there. So sorry, these are the modules. Intravascular volume loss, water loss, and then you restore the patient to a normal hemodynamic state, and now you focus on free water repletion. Just ignore what I've written there. I try to derive it. You have a formula, you know that, okay? The formula is this. You take the deficit is weight times the measured over desired minus 1 times the dosing factor. Patient is male, it's 0.6, and 0.5 female because that reflects the amount of total body water, okay? So in a 50 kilogram male whose sodium is 150, the loss is 1.8 liters approximately. How quickly? You should not do this quickly. Why? Because her serum sodium is high. If I drop it too low, what's going to happen to brain cells? It'll expand, right? So you want to do it really gently. And how gently? The prescribed rate is no more than 0.5 MEQ per hour. So how many hours would that be? 20 hours, because the deficit is 10, right? You want to go from 150 down to 140 at 1/2 MEQ an hour? Take 20 hours to do it, that volume of fluid. Very, very, very gently. You can do a lot of damage if you correct hypernatremia too quickly. Is that clear? There's lots of things going on here, so don't forget. Treat the intravascular volume depletion always as the first directive. Take a step back and then slowly correct the osmolar state with this formula and that time. Okay, let's take the other example, and this is a patient with cirrhosis. So what's happening here? So known cirrhosis has portal hypertension as ascites and comes in with worsening kidney function. So there's no orthostasis. Pressure is kind of low, but not orthostatic. Okay, JVP is seen. It's not high, it's not low. So the range is 5 to 10 approximately. So if you can see a JVP, you're not volume depleted. Okay, but there's tons of ascites. There's no edema, and the patient has asterixis, which is a sign of liver failure. The BUN is 12 and the creatinine is 2. Albumin is 2. So BUN looks normal, creatinine is definitely not normal, and albumin is definitely low. So you send urine lights, and the sodium is quite low at 6 MEQ per liter, and I've done the calculations, so don't worry, it's 0.5% for FeNA. That's low-ish. So the urine volume is really low. So the patient is oliguric. So remember, we need at least 400 to 500 mils a day of urine volume to maintain excretion of toxins, right? So patient is clearly in oliguric acute renal failure with low FeNAs. So what do you think is going on with the volume status? So is there intravascular volume depletion? No, because there's no orthostasis. Although blood pressure is lowish, there's no drop when the patient gets up. Is there extra cellular interstitial volume deficit? No. Skin turgor is normal, there's no edema, there's no overload, there's no underload. Okay? So why is this patient behaving in this manner? It's likely because of the ascites. That's an example of what? Third spacing, remember? So because of portal hypertension and a low albumin, your intravascular fluid, interstitial fluid, is seeping out slowly into the abdominal cavity. Okay? And have you heard of hepatorenal syndrome? Yeah? So this is an example of hepatorenal syndrome, where there's the initial phase of volume depletion and there's an irreversible phase where despite volume depletion, you don't get better. And that's because of severe vasoconstriction in the kidneys. So the only way to know what's going on in this patient is to give back volume. And what volume would you give him? Is it normal saline? I'll give you three: normal saline, albumin, or water? Albumin. Okay, so in patients with, this is probably the only situation where we prefer albumin over saline. It's the patient with cirrhosis in whom the question of volume depletion versus hepatorenal syndrome exists. Okay, and the only way, and there's a prescribed amount, you give a gram per kilo per day times 2 days of albumin to make sure that there's no element of volume depletion which accounts for this patient's kidney failure. If you do not respond to this albumin, there is no volume depletion. This is true hepatorenal syndrome. And that's how we make the differentiation. Because you cannot tell by urine lights, you cannot tell by any other means. You have to give them volume, and the best volume resuscitation is done with albumin at a prescribed amount. Here's another example of third spacing. This is a patient with pancreatic cancer who has undergone this big long operation. You take out the pancreas and the duodenum, and then you do a bypass from the remnant stomach to the jejunum. Okay, so major surgery. And then you see on post-op day 3, there's abdominal distension, and patients getting, although blood pressure is okay, there's a drop in heart rate. There's an increase in heart rate when the patient gets up. And there's no bowel sounds. And you look at the abdominal X-ray, you see these fluid levels, which, what does it imply? It implies that there's intestinal obstruction, right? Because you shouldn't be getting fluid levels inside the gut. And this obstruction is likely what we call adynamic ileus, which is basically the motor function of the intestines have not returned post-operatively. And the patient is secreting all this intestinal fluid. And it's staying there. It's not proceeding. And the only way to get this patient back into a comfortable position is to drop a nasogastric tube and start suctioning it. But what's going to happen when you do that? You'll start losing more and more fluid from your intravascular interstitial compartment where salt and water comes from, right? So there's a classic example of extracellular volume depletion because of third spacing. And the way to treat this patient is to give back what you're losing. So it's intestinal fluid losing sodium, a little bit of potassium, a little bit of bicarb, and water in proportion to the sodium. So you need an isotonic fluid which contains all these substances, and that's what Ringer's lactate is. Ringer's lactate contains sodium, potassium, lactate, which is metabolized to bicarb, and that would be the perfect fluid for this patient. Last slide, I think. Same patient has not had recovery of bowel function. Okay, so you want to give this patient some dextrose. So you've said, okay, you've got the blood pressure back, the patient's peeing, and you're giving back whatever you suck out from the NG tube proportionally, right? That's 5% dextrose and 0.9% normal saline. So do you think the patient's getting enough calories? And the way you do it is, see, what does 5% mean? It's 5 grams per 100 ml of dextrose, right? So if you get about 2.5 liters a day, 5 times 24 deciliters equals 120 grams, right? Which is about 500 calories. So to go up on the calories, just double the amount of dextrose in the fluid. Okay, so you can go to 1,000 calories, which is not unreasonable. And if the patient requires a longer period of being without food, then you start what's called total parenteral nutrition, which contains lipids and amino acids and sugar as a separate line. Okay. So just to bottom line, I think we've talked about the 3 compartments. How do we clinically recognize which compartment is compromised? There's a chart right there. You've got a whole bunch of fluids. You've got to tailor it to which compartment is predominantly affected. Hemorrhage, give back plasma expanders quickly. If it's extracellular volume, give back salt and water, either sodium chloride or Ringer's lactate, depending on the nature of the deficit. And if the patient's got diabetes insipidus or any hyperosmolar state, you just need to give back pure water. Any questions? Sure.
You give just plain water IV, the blood cell is lyse, right?
It lies, yeah.
But if you give dextrose water and the cell immediately eats the dextrose, why don't
It's not immediate, right? So dextrose takes, by the time it equilibrates across the
Tissue.
total body water, then the dextrose is being metabolized.
Okay.
It's about an hour or so.
That's not enough. That's not enough to drop the osmolarity.
No, that's right. It'll do that. Yeah.
Yeah, absolutely.
Is this Ravali?
Yeah.
Okay, yeah. We've got some, but it's as usual. It's tough to get people to. It's one more thing to say. I'm sitting on 3 letters. I'm supposed to write people from other institutions, right? And some weekend have to find to do this, right? It's one more thing. So I do feel for this guy.
Okay, obviously.